So good afternoon. Welcome, everyone. I'm very excited to be hosting my first School of Public Health Grand Rounds. I'm delighted to be part of this process, and also very excited today to welcome two guests who are colleagues of mine for nearly 20 years, both from Bosnia and Herzegovina. The first is Dr. Nino Jovanovic, who is an ophthalmologist and oculoplastic surgeon. She set up Bosnia's first eye injury registry as part of a training program. She has her MPH from the University of Iowa. They'll both do a little introducing of themselves, but I'll give a couple of highlights. And then pretty much single-handedly introduced oculoplastic surgery to the country of Bosnia and Herzegovina, and has since expanded that practice through fellowships all over the world. Also very happy to introduce Majda Turkic, who is a photographer, also completing her PhD at the University of Vienna in gender studies. And the three of us and Nina and Majda have done quite a few public health projects that have included injuries, violence, bullying, especially focused on LGBT youth, using arts-based storytelling approaches, mixed methods approaches. Their new project that they're launching, and one reason they're here, is to talk about an international project focused on physician trauma. So I will turn it over to them.
Hello, everybody. I hope you can hear me and see me well.
Yes.
So my name is Nina Jovanovic, and I'm, as Corey said, I am an MD and I'm an ophthalmologist who will address few topics today. So I will first shortly introduce myself and then present the public health system in Bosnia and actually in the whole region where I live with its challenges and my personal research field of eye injury and trauma. And afterwards, I will probably actually present on behalf of Majda Turkic, who is having some health issues and kind of lost her voice. So she asked me to present what she does on her behalf, but she's here with me. So let's start. So as Corey said, I am a medical doctor, ophthalmologist, and I particularly do a few aspects in eye surgery, which is oculoplastics, anterior segment surgery, and I work a lot with pediatric population. So I'm currently working in a public health facility, is a secondary and partially tertiary medical center, where my time is 100% devoted to patient care, either as inpatient or in the OR. I'm saying this because it means that we are not supposed to do any research, although we work in a clinical settings during our work in a clinic, which is one of the biggest setbacks when it comes to research in my country. So we are supposed to do any research on our free time back home. As Corey mentioned, I did my MPH at the University of Iowa. It was OEH subtrack. And since I chose to do oculoplastics, which hasn't been done in my country previously, I had to pursue training outside of my country, especially United States and Europe. So I have been traveling a lot and spending a lot of time outside of my country and my hospital. And unfortunately, I am actually moving from my country to another one. I'm moving to Croatia and I'm starting my new job in Zagreb. That's the capital city of Croatia. So it's also a transition from a public health facility where I work to private health facility, which is going to be a complete change for me in my practice, but it's very exciting and I can't wait to start a new chapter. When it comes to my research, I did mainly research in eye trauma and injury, and then in oculoplastics, strabismus, and anterior segment surgery. And I'm showing these two pictures to see how I look in my daily settings. This is how I usually look and what I usually do back home. And the bottom picture is my cute beagle dog, Mila, very hyperactive dog. And what I'm actually really proud of on two things that I started oculoplastic service in my country and my hospital. So we serve as a referral center for the whole country. And we have also a lot of patients coming outside of Bosnia to pursue oculoplastic healthcare because it's not offered anywhere else. And I also, within this Academy of Science, which is a larger scientific organization in my country that actually is funded by healthcare professional from United States with a Bosnian Herzegovinian background. I founded ophthalmological platform that serves for education training for young ophthalmologists and students who are specifically interested in ophthalmology. So we every year we make a national conference in ophthalmology, and we bring experts from around the world, especially from United States, to teach students and residents. And we also partner with World Eye Mission to bring equipment and medical experts to Bosnia. So this is about me. So I will advance with a public health organization in Bosnia, which I think you are very interesting to hear, and the challenges that country in transition has. So for those who are not sure what countries in transition mean, those are countries with mainly socialistic and communistic past who are transferring from that kind of market to different kind of economy, which is more liberal and market-friendly oriented. But it does not only mean transition in economy, but also in political aspect and any other aspect that you actually can imagine. Unfortunately, Bosnia and Herzegovina the pace is really slow in this transition, and since the war in Bosnia, it's been a few decades, and we were supposed to already be done with this transition, but unfortunately we aren't. So it's still on, and I'm very pessimistic that it will actually take a lot more than maybe 1 or 2 decades. And just for the references, I'm showing the map of Europe to show you where my country is and where the neighborhood countries are, and that this part of Europe belongs to former Yugoslavia, and this whole area is Balkan. So I think when I speak about public health in Bosnia, I'm speaking on behalf of almost all these countries that belong to Yugoslavia, and even some that weren't, but they're geographically located in Balkan. And we are all facing very similar problems. Some are part of European Union, some aren't, like we aren't, Bosnia is not. We are a candidate member, but still we have our own laws from socialistic time, which are not aligned with European Union's laws, which is a big setback in our system and healthcare delivery. And I would also like to emphasize that even with very weak, broken, and imperfect system of health and public healthcare system in Bosnia, it still kind of works, and it still fulfills needs of people. So it educated me in a good way, and allowed me to do a lot of stuff. So my presentation is not about criticizing my country or my system. It's just to emphasize how different it is from United States and what kind of challenges we face, and where is what are aspects to be improved in that system. So when it comes to public health in Bosnia and other countries in our neighborhood, it is largely organized through Institute of Public Health, who serve as the main facilities for public health infrastructure. And due to our political or administrative organization, we have 2 levels. One is something similar to your state level. It's a canton level, and we have 10 cantons in my country, and one is a federal level. So there's one Crown Institute on the federal level and 10 institutes on cantonal level. but they each have same departments, which are Department for Health Promotion, Social Medicine, Biostatistics, Epidemiology, and Health, Ecology, and Radiation. And I think it's kind of very self-explanatory what is each department in charge for, except maybe for social medicine, because that's a term inherited from socialism, but it mainly serves to monitor and evaluate health indicators in the country and deals with the mental health of people in Bosnia and Herzegovina. So what is really different with us and United States is the fact that we don't have such a diverse people who are dealing with public health. So mainly public health professionals, they come from the medical field. So they are supposed to be medical doctors, and then they go through the process of residency. And we offer 3 specialties or 3 residencies in public health, which are epidemiology and social medicine, equivalent to EpiStat and CBH in the United States, and then hygiene and health ecology, equivalent to CBH and OAH, and healthcare management in Bosnia. So after you are done with medical school, you go for another 3 or 4 years of residency to become public health professional or public health expert. There are, of course, people who are not medical doctors. They still do public health, but they are not considered through public health professionals, nor they can assume some leadership position or lead projects. They are more like adjunct staff or some assistants to the healthcare professionals. That fact put us in a really disadvantaged position because not many medical doctors would choose this career of being in public health, because it's just not that popular in my country and in Balkan in general. In general, first of all, wages are way lower than if you choose some kind of clinical disciplines or surgery. And then I'll be frank, usually if you cannot get residency in some clinical or surgical discipline, or you graduate with medical school with kind of older age after being 30, 33 years old, then you would be offered with public health residency. And so not many people would opt to go into that field. And as you could imagine, since there are so few of them, hospitals and clinics only have 1 or 2 public health professionals who work in that facility, and it's usually hygiene and epidemiology specialists, and they serve as the only 1 person in the whole department, which is usually hygiene and epidemiology service department in a hospital. And I think it's quite different than in United States, not because of these things that I already mentioned, but because there's a huge lack of integration of public health services into healthcare institutions and clinical settings, and lack or almost no interdisciplinary collaboration between clinical field and public health field. Then, as I already mentioned, we don't have time allocated for any kind of research when we are doing our daily job. So everything has to be done after work from our home. So not many research has been done at all in Bosnia. And then we don't have statisticians who would work with us in a clinic to help us with research. So we have to either pay someone to do statistics for us or do it by ourselves. So that all are big disadvantages in terms of research and in terms of collaboration with public health professionals. And at the end, we don't have schools for public health, not on the undergrad nor grad level. When I started my master studies in Bosnia, we had the subtrack in public health, but I remember that there was only 2 persons among 50 of us who actually went into public health grad school, that subtrack, and everybody else went to the either clinical or experimental laboratory subtrack. So at the end, they shut down this subtrack. So now we don't have it even on the grad level. So the age distribution within public health disciplines is also something to worry about, especially for the future, because you can see on these bars that our professionals in public health are kind of old, especially hygiene and health economy sector. We see that almost 80% are above 55 years old. And I have to apologize because I permuted epidemiology should be on the second bar. So epidemiology is the youngest discipline. So if someone opt to go to public health, they would usually choose epidemiology above the other disciplines. So social medicine and healthcare management is kind of half and half, but the epidemiology is the youngest one. So that may not be an issue in future, but definitely other disciplines will have lack of public health professionals in 10, 15 years. Other challenges in healthcare system in general include that we are highly decentralized. And as I already mentioned, in whole countries, we have two entities. So I'm only talking on behalf of one where I live. It's a Federation of Bosnia and Herzegovina. The other one, the Republic of Srpska, is completely separate from us in a political and administrative terms. So we kind of function as two separate countries. So I'm only addressing the part of the federation. So we have 10 cantons, and each canton has their own laws and regulation, which can be pretty different from each other, which is kind of complicates things even more. And then there's a lack of long-term planning and restructuring system inherited from socialism. So as I said, many laws are just rewritten from that period of the 70, 80 years old, and they are not adjusted to new age. And then maybe one of the biggest problems that we are facing now is enormous number of emigration of junior and lately even senior doctors from hospitals from the country towards European Union. So I'm the maybe example of that immigration as well. So after 13 years doing my job in Bosnia, I just decided it's time to move on and go to another country. And it's, I think every day we are losing around 5 or 6 MDs from the country. It's a lot for a country that has only 2.5 million people. So like, for instance, when I started doing my residency, we have 3 days dedicated for general surgery, which means that we had anesthesiology team 3 times a week. Now we have one time a week or one day every 2 weeks. Which is the direct result of the lack of anesthesiologists, not just in my hospital, but in every other hospital, which shows that the healthcare system is kind of collapsing, it's crashing. So our indicator shows that in 5-10 years, we'll be facing with the complete catastrophe in a healthcare system if something is not changed in the country. But even though our government is completely aware of that, there's a lack of investing in new technologies and human resources. So it's basically nothing is done to overcome that problem. And of course, there's the issue with financing and money income in different cantons. So some hospital has more money than other, and that also affects of the human resources that can be attracted to different healthcare facilities. Talking about numbers in public health, as I said, we are a country of 2.5 million people, but we only have 44 epidemiologists in this country, which is almost 30% decrease compared to 2008. I'm showing numbers before pandemic because I think they're more objective. And the number of hygiene health ecology specialists is even smaller. It's only 13 people with a, again, decrease from a year before. And then social medicine and healthcare management, 15 again, decrease of 21% from the previous year. So according to our normatives in healthcare system, we are missing almost 50% of public health discipline doctors or public health professionals. When it comes to vital statistics in Bosnia, our general mortality rates unadjusted for age are 976 per 100,000 people. Compared to US, it's more. US, I found it's 715. And our leading mortality rates are very similar to other European countries, and majority belongs to cardiovascular diseases, and then to malignant neoplasm, endocrine metabolic diseases, respiratory diseases, and other conditions. But when it comes to specific mortality, specific causes of mortality, again, cardiovascular diseases are on the first place, with acute myocardial infarct being first one, and then cerebrovascular stroke, the second one, then malignant lung and bronchi neoplasm, idiopathic hypertension, and chronic ischemic heart diseases. This is very similar to other countries, but still our numbers are they're higher than any other countries in European Union, and as you can see in the United States. So reason for this high mortality is of course multi-causal, but indicator shows that one of the main risk factors that is contributing for such a high mortality rates is a very high air pollution that comes from households and cars exhaust fumes, from unregulated industry pollutions. Then I would add a minimal level of awareness for community health protection versus individual, along with very low socioeconomic conditions, which means that if a family would like to change from the traditional way of heating on coal or woods to some for the natural gas or some alternative ways for heating, this government is not doing anything to help them transition. There are few programs that subsidize these interventions, but they're very limited, and most of the families, they just have low income, so they cannot transition from their own financing to different types of heating or energy sources. So they, from year to year, they just continue with the same things, same kind of heating, same kind of fuel consumption. So nothing has been changing for years. And then we are one of the highest meat consumptions and processing countries, I think next to France in Europe. And there's also no enforcement on the regulation of inside cigarette smoking. We have laws that prohibits inside cigarette smoking that will come on power maybe in next year, but still there's no enforcement to make the confined spaces for people who would still like to smoke inside. So nothing has been done on making the infrastructure works for the next year when the law will be enforced. So according to the public cross-sectional survey, there's been 44% of adults that use tobacco, which is, I think, one of the highest rates in Europe. And when it comes to pollution, I think that's the major problem in Bosnia. So almost every winter, our capital city and probably at least 100 miles from the capital city, including a city where I work, Zenica, and some other smaller city, has been voted or has been like the cities with the highest pollution in the world. And when you just come to my country in winter, it's horrible. You cannot see almost anything. So every day I commute from Sarajevo to Zenica, and it's a 50 miles long commute. So it takes me usually 1 hour and 40 minutes during winter time because I have to drive so slowly because of the very fog and smog and very low visibility. So these dangerous substances in the air, they come from floating. They are actually floating particles: ozone, nitrogen oxide, sulfur dioxide, carbon monoxide, and polycyclic aromatic hydrocarbons. And in addition to that, our survey of the school-age children showed that almost a quarter of school-age children use some type of tobacco product, which is really high. And then 60% of school-age children use hookah or shisha. It's becoming really popular in Bosnia. And then almost 60% are exposed to secondhand tobacco smoke in homes or indoor public spaces, with 60% of school-age children who are allowed to buy cigarettes from a kiosk or store, and almost they have never been stopped or declined buying these products. So this is how air looks like during winter. As I said, air pollution comes from the industry, but since it's very predominant during winter, we know that it comes from homes and also car exhaust fumes. And these two pictures are really illustrative how the air looks like. Usually during winter, at least in total 20 or 30 days a year, our airport is shut down. There are no landing or departure from the airport because the visibility is just so low and so bad. So we have to, if we would like to go back to Sarajevo, we usually have to land either Zagreb or Belgrade, and then ride a bus or a car to get to get home to Sarajevo. You can see that young people, they smoke shisha or they smoke cigarettes very frequently. So that's about the topic of challenges in public health. So I would like to continue with my research that we have done in public health. It's about eye injuries and trauma. And I think since 2012, I have been involved in eye trauma research with the help of IPRC and Corinne Piquesa. And first thing that we did that we're really proud of is we implemented the hospital-based eye injury trauma registry in the hospital where I work. And it was based on the United States Eye Injury Register that was done or published by International Society of Ocular Trauma, and it was availably distributed in the as a publication, and encouraged for every country to use it, to adjust it and adopt it in their own country, in their own system. So it is a uniform and detailed database for all severe eye injuries. And when I say severe, I mean it is a proxy name for injuries that are hospitalized or admitted to hospital. So they either require surgery or very close monitoring in order not to decrease vision or final visual acuity. And what is important that we did is that we didn't just set this registry on one laptop or in a specific place in a hospital, but we managed working with our IT team and the hospital management to incorporate that injury registry within the hospital software. So it's there, it's in the system in the hospital, and it will always stay there. So even if I leave the country, whatever changes are made, it will always be part of the hospital informational system, and it will be available for use and to input data and extract data. So the registry is based on data that are taken from the patients, and they're entered by a medical doctor who is examining the patients. And I will just show you how it looks like. So you enter it online, and then you can take out or download PDF version. So this first part of the registry is about demographic data of a patient, the doctor that MD that is examining patients, and where the injury happened, then the work relatedness of an injury, eye protection use, mechanism and source of injuries, and then clinical data about which part of the eye is injured, and very specific clinical data that are beyond the scope of this talk. And then the diagnosis, of course, the code, which are very important for further statistical use. And at the end, we calculate a score that is called ocular trauma score, where we can very closely estimate the severity of an injury and the outcomes that we assume the injury will have after management or surgery of anything that the injury needs. So the benefits of having this registry is that it helps understand and estimate the burden of eye injuries, explore multi-causality, and it helps us to build strategies and tools for prevention and management. And of course, it helps us as a database for further research. So you can extract according to the code, either is it like closed eye injury, open eye injury, is it laceration, or is it a rupture? And you can see statistics, and you can extract any other data that you need for statistical or research purposes. So with the help of the registry and our further investigation, we managed to publish several manuscripts on eye injuries. I am showing the part of them. Some are not still published. We are working on them. We are working on that. But we basically first did research on adult eye injuries, and we wanted to see first occupational eye injuries and then non-work related eye injuries. So in our first research that we published, we did 9-year retrospective study of patients who were admitted to a healthcare facility in Zenica, where I work. And the research showed that more than a third of injuries actually occurred at home, while farms and industrial settings approximately accounted for 1/5 of injuries, which is, it came as a surprise during the research to realize that majority of injuries actually happen at home. So it was really useful to start thinking about future strategies that you can build to prevent these injuries, because I think maybe it is the hardest to create interventions to prevent injuries at home, especially when it comes to adults. It is, I think, way more easier to work on strategies to prevent industrial or agricultural injuries than home injuries, because of the, first of all, diversity of these injuries, and really like a very sometimes they are so unpredictable, and it cannot be prevented. But also what I personally discovered, the pattern of how it happens in home, is because people would do some daily stuff like repairment or something that includes manual work in the house without using any eye protection, because usually they would say, when I speak with them, they would say, it's just something that I do for 5 minutes. I just thought that it will take me 3 minutes to hang the picture, and I thought nothing would happen, but usually it does happen, and it can be devastating. So when I was doing this research, I also did a conversation or talk with my patients about need for protection, eye protection, and how very cheap eye protection is, and what kind of eye protection they should be used. So it wasn't just research, it was also an intervention of a patient that I saw in my clinical practice. And sometimes it would be repeated injuries, some would have 9 or 10 injuries that happened in the lifespan, and they would still repeat the same mistakes. So I really try to talk and to persuade them that having an eye protection is the cheapest and the most effective way for protecting them. But also very importantly and interestingly, our occupational eye injury research showed us that agricultural workers were 8 times more likely to experience work-related eye injury compared to manual workers, and that organic material was significantly more likely to cause war-related eye injury than other sources of injuries. So that showed us that also interventions has to be done among farmers and agricultural workers, and that is a huge gap, huge lack of interventions in my countries that needs to be addressed. After this research, we addressed non-occupational eye injuries, and we had a sample of almost 300 severe eye injuries that we included in the research. And the main goal was to create a model where we wanted to show what kind of clinical characteristics and demographic characteristics affect to worse visual acuity prognosis and worse and bad outcome. So we try to create a model that can be used in a daily practice by physician or young residents to estimate how severe eye injury is and what kind of prognosis it has. So to aid young doctors, young physicians in decision whether they should go into OR and repair eye injury at midnight, or they should wait until morning when the senior doctor comes and try to repair the injury. So like, for example, if there's a younger junior physician on staff and injury comes with a really bad eye visual prognosis, then it would be advocated for young resident or young physician to go and repair, because they also need training. But if it was a person with a really good, with severe eye injury, but the good visual acuity prognosis, then it would be advisable for them to wait until morning or just to call some senior staff physician to help them in the OR. So we think that this model is really useful for practice, for decision-making process, and we identified characteristics that were included in the model that told us with a high predictability how severe an injury will be for future and what kind of visual outcome the injury will have. And then we turn to the pediatric population. We looked for the all children eye injuries for the lifespan of 0 to 18 years old, because we wanted to investigate state and trait-like risk factors that lead to childhood eye injuries. And since I can say, fortunately, eye injuries, severe eye injuries were not that common among children, we didn't have such a big sample like we had with adult eye injuries. So we turned to case crossover study methodology because of the smaller sample size. And what we discovered in our research that, of course, unusual activities had higher odds for being injured than engaging in usual activities. Like, for instance, if a girl would dress mother dress and take mother's shoes, high heels, and walk around the house. We had one case like that. It was named like unusual activity, and they had these kind of activities had higher odds of sustaining eye injury than engaging in usual activities. And then working around the house, especially helping parents. And the pattern was chopping woods with a father or mother in the house for heating, show that that has higher odds of being eye injured than engaging in other normal activities, even like running or playing or anything else. And then, of course, intermediate and calm activity level had protective adjusted odds for not being, or crude odds ratio for not being injured, and then being supervised were also protective factors, but less than 7 hours sleep showed that also increased odds for being injured than sleeping 7 or more hours a day. And afterwards, we did another study that, because even though they're not very common, when they happen, it can be they can be very devastating, because a child eye is growing and it's still developing. So any injury that happens in adulthood versus childhood is different because of the very high rates of scarring, and the scarring is although really good for wound healing, it's really bad when it comes to an eye, because it can lead to secondary glaucoma, retinal detachment, or any other possible adverse outcome. So having eye injury, severe eye injury in childhood can be much more devastating than in adulthood, adult age. So we wanted to see how they reflect academic success and social inclusion afterwards. And we did another study that showed that it does affect academic success, but we haven't published that research, but we are working on that, and hope it will happen soon. So at the end, I would like to thank you for your attention and show a few pictures with Corinne Picasa. It's my graduation day on the first picture, and then the exhibition that we had in Iowa a few years ago with Majda and me. So this is my email if you want to reach me for more questions, and I thank you for the attention. And then we will continue with the second part of our talk. It's art. I think it's more interesting than the first part, the statistics and public health. So this is where Majda Turkic should step in. So as Corey mentioned, Majda Turkic is, she's a PhD candidate at the Academy of Fine Arts in Vienna, and she is especially interested in exploring architectural consequences after the war in Bosnia and Herzegovina as a reflection of colonial past in Bosnia, which is not actually a real colonial past, but something that is a mixture between the imperialistic and colonialistic powers that were ruling Bosnia and whole region. So she wants to see how that reflects on the architecture after war in Bosnia and Herzegovina. But other than that, she's a photographer, and she met Corey, I think 2014, and then they agreed how important art is in public health and how many activities and initiatives can be reached through art. So they did several projects with the photo voice methodology that were community engaged and especially focused on youth and students. So she did cyberbullying projects, and then intimate violence, art-based prevention. And as a big success, they succeed to open a youth center in our city where Majda lives, which I will show you how it looks like. This is a youth center that is run by 4 NGOs. This was a big dream for Majda, where she can address culture and art for young people and students, and adopting at the same time disciplines of public health, and engage them to work in their community to do different public health initiatives. These are the pictures of installation that were held in front of the youth center. One of the projects, I think that project was named Hear Us. It deals with people with hearing disabilities, which Majda also has. So it was really close to her. And these installations were set up in the whole cities, as well as in front of the youth center, so people can learn the sign language and be aware of the problems that people with hearing impairment face every day. And she's also collaborating with many international NGOs like USAID, and then OSC and others, and governmental institutions that are funded and supported by the Ministry of Culture, Ministry of Education in the canton of Zenica. So I think that quickly she would like me to show you how to exit this. I think I stopped sharing the screen. Yeah.
If you click, and then it should bring the menu to the top. Okay.
Sorry.
So you're not sharing right now.
I just want to pick something else. How can I choose this? And I want to now share again. Share screen. Okay, share. Okay, sorry for this. Can you all see this PDF that I'm sharing?
Yes.
Yes, we can see it.
Okay, so this is the last product that Majda did with her students. It's a book on a topic why people hate. It's a product of the project of intimate violence and violence prevention in Bosnia, and she worked with a group of young people. Some were new in her project, some were people that she worked for the last 7 or 6 years, and they created the whole bunch of text that were talking about different aspects of violence. So some were made by professionals in the fields, and some were written by students, and how they see violence. And what Majda always says when she describes this project is that at first, all students are so reluctant to speak about intimate violence and violence that they had and they faced in the community, but she works with them closely and listens to them. And then after some times, they open up and they share stories, either their personal stories or something that they saw in their community or family. And then they work together on trying to find a way how to express that artistically. And usually they usually use photography as a tool, sometimes other visual tools. And then they create really great art that I will show you in this book. So this is the melancholy, the topic that she discovered with the student about the mental health issues that she faced because of some intimate violence that she faced in her family. This is part of the series. And then the question of nudity, which is a kind of taboo in our country. So how the young woman should feel about their body and their self-expression. So this was a photography that was made by her student. So every student, not just each student were engaged in making a photography or art, but also they were instructed or said to write a piece, a story, their intimate story about the topic that they were passionate about. And they would read a lot, and they had a theoretical background. With Majda, it was just about photography or art. They also read Susan Sontag and Leibovitz and many philosophers who would address the topic of violence and fear and aggression. So they kind of approached this topic from many angles to create art that was meaningful and that reflected their most intimate ideas and fears. So I think Majda would be happy to share this PDF with you after we are done. because it's almost 100-page long, and we don't have time now to show everything. But this is how the book looks like. And if you want, she can send you via physical email a copy of the book if you would like to have it in your own collection. And what is important that each of the projects ends up with exhibition where the youth and students are kind of in a focus. So they not just learn about photography, they learn about creating exhibition and exhibiting and talking to people, which is kind of something that gives them that empowers them to work within a community and to communicate with people. So I think this is it. We only have 5 minutes left for a Q&A, and I'm sorry I was too long. So
Why don't you stop sharing? Don't do that. Do that.
Okay.
Stop sharing.
Oh, stop sharing. Okay. 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 Yeah. So,
Any questions? Thank you, everyone, for attending. We really appreciate it. This is Majda and Nina's first visit to San Diego, but I hope not their last. So hopefully, oh, and Cheryl, you're for Dean Anderson.
Yeah. Hi, everyone. And thank you so much, Dr. Jovanovic, for that wonderful presentation and for covering for your colleague. I learned so much about the public health system in Bosnia, and I have 10 questions, but I'm going to try to prioritize just based on what I think you wanted to share with us, which was essentially, the way training happens for public health and the way public health is being executed has some strengths clearly, but there may be some opportunities to do things differently. And I just wondered, having had a pandemic, with us since 2020, has that brought additional funding and infrastructure into Bosnia for public health? And then I'm curious, how did you all fare? And did it expose some of the potential need that I think you summarized for us so well, so that maybe those in sectors of influence can begin to support and bolster the public health infrastructure there more so?
thank you, Dean Anderson, for your question. Yes, we had a lot of aid during pandemic, and it came at the very beginning of the pandemic. And I remember that my hospital received big fund, but unfortunately, I remember that we were told, like, we got so much money, so please, like, write what you need, but it doesn't have to be related to pandemic, but write what you need, like, in general, because we can use that money for other things. So this is what happened in Bosnia, and I think in many countries in our neighborhood, that even money that were supposed to be used for the infrastructure building were used for different things. But I think the public health sector, they are receiving a lot of money from the government. So their biggest issue is not funding. They have, I think, kind of really good infrastructure, but the problem is the human resources and the leadership and the advocacy and how is advertised within the medical community, and the problem of attracting people. So I don't think it's specifically about funding, but more to how to attract young people after medical school to be more involved in public health, and maybe how to extend public health to different disciplines and make it more multi-disciplinary than just the medical doctors. So I think that's the main issue. I don't know if that answers your question.
It does answer my question, and one of the opportunities here might be, you described, sort of some of the issues that are happening with smoking and shisha pipes and your own work with injury prevention. I think in each of those instances, the opportunities that other countries have seen, and even here in the US, around creating gender equity, and having very clear data now that places where the girl child is seen and valued, and women have more equitable resources, we find that the overall health of families and communities improve significantly. And so that's a possible thing to think about as you move forward in your own work, and as the agenda for public health moves forward within the country, is to really ensure that there's a focus on gender equity and of course, aging well.
Yeah, definitely. Yes, I agree. Thank you for your inputs.
Good. Well, Psycho let us know that we need to have a hard stop at 1 because the room is booked by another group who's outside. So I want to thank you all again for attending. Thank you, Nina and Majda, for sharing your work with us, and look forward to the next Rotterdam School of Public Health Grand Rounds.
Oh, I forgot to thank you all for inviting me and organizing this. I like your call. I like your campus and university so much. It's a great place to be, and we are so delighted and honored to be here and for having the opportunity to speak in front of such great experts and names. So thank you so much for this opportunity.
Thank you very much.
Thank you.
Bye. Have a nice day.
Bye.
Bye-bye.